Good afternoon, everyone. This is Jason Crosby of Strategic Healthcare Partners. I want to thank you all for joining us today for our webinar, Turning Data into Information, being presented by Mike Scribner, our principal, and Janie Marson, our VP of Data Analytics, which this presentation is a recap of a live presentation they did for the Georgia Association of Ambulatory Surgery Centers in Atlanta just over a month ago. So we want to thank that association for inviting and hosting that conference, well-attended conference. Janie, if you'll do the next slide. As we get started, however, a few housekeeping notes. Everybody is starting on mute with their cameras off. So if you have a question that you would like to be asked, please use the React function at the top or QA function or chat, and we'll be sure that those questions are answered, and you should see those at the top of the screen. Also, our webinar is being recorded, so everybody is aware, and will be uploaded to our website here in the coming days. Again, if you are unfamiliar with Strategic Healthcare Partners, you see there on the screen, Mike Scribner along with John Crew are two principals, founded in 2009. Lots and lots of experience in the field between them and our staff, represent primarily rural hospitals, as well as many physicians, both employed and independent, and ambulatory surgery centers, thus the content you guys will hear today. And then the services you see that we do provide to those services or to those entities. And with that, let's go ahead and get started. I know we're a few minutes in. Mike, why don't you go ahead and get us started today?
Yeah, let's do it. Hey, thanks, y'all. I appreciate y'all coming to listen to us today, ask questions, and let's keep this interactive. Yeah, I guess I'll start here. That what we typically see in our ASCs is, I come from a background at Memorial and Savannah, and the resources that we had available, both from a managed care and a data analytics perspective, were pretty robust. That typically is not replicated in our ASCs. That those that are born out of independent physician practices tend to be pretty skinny in how they are administratively run. Thus, a lot of times there's not a CFO, there's not a lot of in-house analyst support. So there tends to be a ton of data that's available within all the systems that are out there, but there's this gap between this mass of data that's available and what kind of typically gets turned into decision-making tools within the practice. The other problem that we kind of tend to see is that, and we're in this position a lot where, because a lot of y'all run from cash-based accounting, and so you're looking at the cash-based income statement, and the doctors are saying, I'm working as hard as I used to. However, our bottom line and what I'm able to draw out of the ASC side is lower, or the practice side, either one, and it's lower. And the problem is that the financial statements, as reported cash basis wise, tend to be a lagging indicator for almost all the problems that you'd have. You got a revenue cycle problem, a volume slowdown, some kind of cash flow interruption, payer mix has shifted, and you don't see it in the month that it occurs or the month after it occurs. You see it when the collections slow down later on. So you're in this position where, or we're in this position if we get drawn in on it, where the question is, I don't know for sure, but I think volume is basically the same, but cash is down by 20% over the last 60 days. What's happened? And that's A, accrual-based financials probably would have helped with that. B, that's a lot of the issues with running sort of financially, with the barometer being the cash basis financials. And so our typical question as we're starting into this is, as I'll get into the next couple of slides, is not like what will the system produce, it's what information do you need, and what questions go kind of not very well answered, or not answered from a specific data points underneath it. So like that last point, we run into a lot of time where there's a data point that's available, but there's not a comparison point to it. So our mantra internally is that all data has to have some kind of a comparison point, either its own trend, a benchmark, something, in order to determine whether or not it's good or bad. It's not, and the one that we sort of tend to throw under the bus a lot is like net to gross, net collections to gross revenue. Is 32% a good number? Well, very hard to tell unless you're looking at your own trend, or what you're charging as a percentage Medicare, and you have a methodology to tie that back to something to tell you whether or not you're successful or not. And so it's those are very hard to do. Next slide. So in terms of as I said a minute ago, the our kind of opening thought, and again, if you're on this and your background's more clinical, and a lot of these financial measurements that we're about to go through are less helpful to you, um, don't dismiss this completely, because when we're sort of tasked with coming up kind of new soup to nuts with the array of reporting that should be in place, our opening question is not what the system can do. The question is, what do I need to know? When do I need to know it? What do we know in decision making? What are you guessing at? And so, a lot of the things we're going to talk about today tend to be more financially driven because that's where we live. But you can also ask this from a quality perspective, volume, sort of quality turnaround, operational throughput measurements. All those sort of metrics are valid, but it's the ultimate question is, what do I need to know when? What am I guessing at? What do I have hard data underneath? Next slide. So we're going to take this discussion from the perspective of really kind of revenue cycle, volume, profitability, and managed care, and then sort of a more of a shorter term version of it to kind of hit at the cash flow of all that. But the point would be that, again, you think about the range of reporting and when you need it from the perspective of kind of the key range of decisions that you have to make, and thinking about it from that perspective. And thus, at least from our perspective, from a financial looking at it financially, our goal is to try to figure out the opportunities and assign a value to them so that you can prioritize what your improvement activities are based on what has the largest financial return. We get caught in this world, in our managed care world, as well as our financial financial analytical hat on, of chasing down items that, if you fix it, it's only worth $5,000 to the practice or the ASC, versus other items that may be far more material to the bottom line. And without some kind of quantification of those issues and some kind of pulling together of that into an improvement plan, it tends to be kind of this vague unknown where we're sort of grabbing for various initiatives that we think might help, but have done no quantification of how much, if successful, they're worth. Next slide. So, and I get this is going to feel like a lot of overkill, but when we sort of design, again, a decision support function for folks, whether it's hospital, ASC, practice, what have you, the question tends to be, what do you need to know daily? What do you need to know weekly, monthly? And then what do you need to know kind of more farther out, where you just need to kind of reset your understanding of it? And then what's kind of ad hoc that you need available when you need it, but you just don't tend to know exactly when you need it or when the situation might arise for it. And so to kind of put some, just a couple of examples with these from a cash flow perspective, I'll go over a slide or two that from a daily cash flow mechanism to kind of understand where we stand with the ins and outs of that. That feels like something you would want to know daily. Yeah, it's a bit of a pain in the butt to pull together, and maybe you only want it weekly, but that information might be helpful to know, a fairly frequent clip, from a revenue cycle perspective, where we are versus benchmarks. That feels like a monthly kind of analysis, and where you kind of update your initiatives and put some targets with that and keep that rolling forward. And I won't go through all of these, but the point is that being able to replicate the key reports in some kind of cadence that goes along with the decisions that you're making around all of it. The reporting needs to match that cadence. And for example, if you're halfway through the month and you know that you're way off of the cash target for the month, then what information do you need to know what's going wrong for you to do something about that? And that's what this is intended to at least show examples of. Go to the next slide. So one example of this, we call it a daily flash report or a daily cash flow report. That what this report does, and several of our clients have deployed this, is a look at the left hand side is cash in, and then the month to date collections versus average versus prior month versus target or what have you. The next section is the cash out and the ending cash balance. And again, before you start freaking out that this is just way too much to do, when it's rolling, it only takes about 10, 15 minutes a day to do. And so the next section is daily charges posted. And again, once you sort of have the averages in mind and like in the example that's deployed here, this is the month of June, and that this ASC is reporting $70,500 a month, a day in charges versus 73,000 as their average. So a little bit off. What's their AP, outstanding AR, days in AR for that day, and then the volume or whatever volume to track makes sense to you by whatever methodology. In this, it's done by doctor, but whatever that methodology would be. My point with this is that it's important to keep up with cash and all that kind of good stuff. But that last bullet point, if you were to track this, once you've got it in rhythm about 3 months in a row, you'll know the bottom line that the accountant's going to come up with before you get the financials. And so it tends to be a little bit of an early warning to tell the physicians up or down before you wait, a couple of weeks to get the information from the accountants. Next slide. This next one, it's in my mind, it's a little underutilized because we have a couple clients that use it, but not so much. But one of the things that kind of tends to is kind of an extension of the point I was bringing up before, that the doctors, getting them to understand where the cash flow sits, when distributions might be able to be done, and being able to project that out without just kind of waiting for financials to occur month after month after month, and then just kind of guess at it at the end, can be done. And so the point of this is, what if you took your cash flow over the last 90 to 180 days and projected it forward, and then layered into that the larger payments that you have coming, when take backs in, inflows, all that. And if you push that out far enough, you can sort of predict when there's going to be when there's going to be money for a distribution, when you might be going the other way and you might need to pull down on the LLC and make that not we're in this position, got to make payroll, and so doctors, we need funding right now. It's to be able to kind of project that out ahead of time and come up with mins and maxes around all that to give some heads up to it, as well as sort of keep tabs on it yourself to kind of know what's going on. And again, it feels like a pain in the butt. Once it's set up, the daily version of it is fairly straightforward. You're only updating this maybe once a month. And so it's just a matter of, another methodology, being able to kind of keep up with it a little bit better. Next slide. Janie, you taking over?
Yes, sir. Good afternoon, everyone. I'm Janie Morrison. It's nice to meet you. And I'm going to talk through the next few slides where we're going to shift a little bit into the idea of Mike's covered with us kind of what are the things that we need and how frequently do we need them. And the next section of what we're going to look into is what are the sort of revenue cycle reports that we can look at to help us monitor those things and really identify problems or be ahead of the game before we get there. So the first one we're going to look at is a little bit of a volume snapshot. Are we sort of trending? What's happening overall with our book of business? You can cut this a handful of different ways. This one happens to be separated by provider and then looking at the system in aggregate for total amounts. What we're doing here is, and this will be consistent through our reporting, it's just our methodology. In looking at benchmarking things, if you're going to benchmark, we have to have some sort of target. And for most practices, some specialties are a little bit different, but indexing to Medicare in some mechanism should give us a sense of kind of the overall performance. We don't want to be paid sub-Medicare. We don't want to be trading sub-Medicare, but trying to match up each and every single service that we deliver to an actual Medicare reimbursement methodology can be very cumbersome. So our method of doing that is a matter of indexing. So, to walk through sort of the quick math of that, if Medicare pays us 50 cents for whatever we're doing and Blue Cross is paying us 75 cents, then we would say we're getting 150% of Medicare for Blue Cross. And so that's kind of going to give us that benchmark, because our charges are consistent, our reimbursement should be relatively consistent, our patient mix and the services that we're delivering should be in a lot of cases very consistent. Of course, all of those things can change it and can skew it a little bit, so we have to know our book of what we're delivering. This again is looking for comparing our providers, our discount to Medicare, kind of how we were trending in the prior period, which is this section, versus the current period, and just looking for changes here. And then reading across here to determine if any of these shifts are really coming from global shifts in our payer mix. Okay. Anything to add on that, Mike?
Yeah, that last bullet point, just to kind of expound on that just a little bit, is that it's hard to overstate how much we dislike transaction-based reporting. That when y'all look at your reports and you see the charges posted for the month, the cash posted for the month, contractuals posted for the month, how the disconnects between those as the posting occurs end up skewing the reporting to where it's typically not very helpful. You have to go back and shift and report it by a data service in order to see meaningful trends of whether or not your reimbursement is actually, improving or declining.
Thank you. The next version of what we look at, again, as Mike was saying, looking at date of service driven, we're going to look at resolved charges. If we're going back and looking at things historically, we want to see the charges that have had some sort of adjudicated transaction posted against them, so that we're, again, benchmarking things, comparing apples to apples. This is looking at kind of the reimbursement from both our contractual and obligations, what we're being posted as allowed, what we're receiving from insurance, and what we're receiving from patients, and then how we're doing in collecting that final adjudicated amount to bring us to a total resolved portion of collection. Again, it's looking at how our payers are reimbursing us, how our service volume is looking, where we have opportunities for really high balances that we might need to be collecting, or where we're just sort of falling a little bit short in pursuing patient collection amounts. Anything else on that, Mike?
Nope.
The next item that we're going to look at is, again, just versions of this. This is looking a little bit more detail at an individual payer, looking at it by our various providers. This could be done by service locations. It could be done by service type. If you're a multi-specialty ASC and you want to see how your orthopedic cases are performing versus your eye cases, if you're doing both of those, you can see which things are reimbursing and how that's all looking to sort of, again, compare one section to another, but really being able to hone in and identify if there are particular service lines, particular providers that are doing something a little bit different. This particular one, the provider is collecting much better than the rest of the practice. So what's going on? Is there something with their billing staff? Is there something about their patients? Is there more throughput that's driving that?
Or if there's coding differences, and you'll get into that a little bit later on, but we've got one or a couple of very specific situations where, the practice bell curves, E&Ms around a 3 with the exception of one provider, or the other way, it bell curves close to a 4 due to the nature of their severity of their patients, and one is almost exclusively 3s. And so, he's getting paid 15% less than everybody else, and it's same work, it's strictly a coding issue. But knowing it at this level prompts you to ask the right question to go do the next analysis to figure it out.
Another, looking at things in aggregate, and this is one of my themes as we'll go through, breaking things down and not just looking at the very top line of things. And in this example, we have an overall days in AR for the practice of 27 days, which is great. We'd look at that as the top line number and we'd keep moving. But without looking through the detail, we might miss that we do have some significant volume that is paying much, much slower. And before this starts to impact or trickle things down to the rest of our payer mix, what's going on here? And in some cases, there are very specific things that we can identify that have happened with that payer, the United thing earlier this year. But in some cases, it may be something's changed in an address. Is this date trending? Were we at 50 days in AR for this bucket of payers a month ago, and now we're up? Is that creeping up? And so that we can, again, get ahead of things before they become more of an issue. Okay.
Yeah, and this is kind of a real life example that everybody in here, I guarantee you, if you looked at your payer mix over the last 5 years, you would see this other commercial bucket, which is non-Blue Cross commercial, all that junk. It's been drifting up over time. They may be accessing Cigna or whoever, but it's some other payer or other adjudicator over the top of that. And they simply pay way slower than everybody else. But we tend not to go whip up on them because individually they're so small that it's 0.2% of your payer mix. Cumulatively now it's 4, 5, 6, 7% of your payer mix. And you say from this example, it pays in double the time, which is increasingly an issue for everybody.
So beyond looking at our days in AR, looking at kind of how are our encounters trending. And again, if we look at things in a very global manner, we could look at our average encounter. The beginning of the period is paying $229. Down here, it's paying $230. We've got some slight improvement. We're really pleased with that. But what else is going on? We'd look at what's happening in particular with Blue Cross. We were in the 300s a year and a half ago, and now we're down at 250, 275. And so while we've had some pickups in some other areas, if we don't drill into it, at least periodically, not that you need to do this every week, every month, but once a quarter, twice a year, to see what's happening in things. Have we negotiated perhaps a new contract and things aren't performing the way they are? Has Blue Cross unilaterally issued a fee schedule change that they didn't provide notification, or they opted to send that to some obscure address? What is really going on with our things, and just monitoring the ongoing health so that we don't have these problems that sort of creep up 3 months, 6 months from now, and we weren't anticipating them and we don't know how to react. Okay. Again, back to the idea that this has to be date of service driven, because this sort of information can very, very easily be hidden if we're just looking at transactional information.
100%.
Mm-hmm. And patient liability collections. And this is, again, a lot of this is internal reporting that we've developed. Most systems provide some metric to allow you to see how you're collecting on things. We choose to group these in kind of all of our self-pay patients after insurance is how we're looking at this particular cut. And what we're looking at are the total charges month by month, again, date of service driven, what we estimate the final patient liability. So these are based on the discount percentages that we're seeing, what's actually been adjudicated, what's sitting there. As we get into more current months, this is going to be some ratio of percentages to that to anticipate it. And what are we seeing as collected up front? This portion is dated, is transaction based, so that we're looking, did we collect that while we had the patient in hand, while they came to the ASC? Did we collect it before the surgery was scheduled? And we can see very real dollars dropping. Charges are down ever so slightly, but not enough to warrant that. These sections here that are in this bold italic are projections of where we think our final collections are going to be. And then this is really helping us try to identify where are the breakdowns in our process if things are changing. We've got some improvement in collections in our 30s, 60s, probably after first set of statements have gone out. Do we need to consider an early out vendor? Are we sending things to bad debt? But what are we projecting as our total completion? What are we projecting as our total patient cash collection, and ultimately what amount of our total allowed? Because you spend a lot of time negotiating contracts and trying to get better contractual reimbursement. But if you don't go after every penny that you're due, then you've done all that work on the front end, which is often very difficult work and very time consuming. But this is all due to poor place of service collections.
Yeah, and a scheduled service like, y'all's surgical cases tend to be, this one is at their collection percentage is 75% of allowable, like Janie was just alluding to. The benchmark should be at least 95 for y'all. I get that you're in a rural area and that there's a perception of, or that some of you rural areas, some of you are urban area, and that there may be a different perception of how much your patients can pay and how much your physicians are how hard they're willing to be to delay cases, ask for payment up front, all that kind of good stuff. But in general, we have too many examples of well-performing 95% and up of allowable clients that this is not, this kind of result doesn't stick out like a sore thumb. It's just, and what I love about this report is that your next question then would be, well, is it a point of service? Is it an early out, or is it a collection agency issue? And in this case, it almost always would be a point of service issue. But in this case, it just screams that, because they're only walking away with 17, 18% of a dollar of allowable ultimately owed that they're collecting up front. It's just abysmal. And my guess is, for those of you on the phone, most of you don't know this number off the top of your head. And that's not a slam. It's just like, y'all have a billion things to do. And my guess is you probably know your net to gross. You might know your percentage of allowable collected, but understanding, kind of broken down by payer, what percentage of a dollar of patient liability you're collecting kind of by type of patient is, we think, very helpful, and typically results in a 6-figure improvement plan being needed. Go forth.
Alrighty. Taking a little bit of a turn, other things to look at, what are we seeing as denials? Because that's ultimately going to impact our payer percentages as well. This isn't based on denial codes, but the goal is really to look at what are things to figure out about what's happening in our system. Is it a payer issue? This would drive to the idea that it's certainly a payer issue. We're saying far more Blue Cross, and then kind of bringing down, are there particular codes that are at issue? So in some cases, we pull these reports and the practices will, my very favorite example is there's an after hours code in case you're delivering services after hours. And a lot of practices will bill for that, not expecting to be reimbursed. Excuse me. But occasionally they will be reimbursed, so they're willing to take the contractual adjustment and at least try. But having that show up on this list isn't really helpful, but we can very easily trim down to the codes that, you expect to get paid. When you start seeing, E&M codes in here, regular surgical codes, these are a bit of an issue, and they at least point us in a direction to decide what is it that we need to do next. Again, this isn't denial code based. This is simply looking at, we posted a charge and then we posted adjustments that netted absolute zero money coming into the practice as a result of performing that service. Anything to add there, Mike?
No, that's good.
And so how we can start to detail this, we can look at kind of the individual, these are the charges that we can go back to. We can look at all of the individual CPT codes. We've included counter numbers when we prepare these. Again, it should be something that your system could generate, or that you should be able to extract some data, see if there's sort of times of maybe there were some particular billing issues or some particular types of service that were things that just weren't covered, and we're not really surprised that they weren't reimbursed. Okay. The flip side of this is, what are the things that are being paid at 100%? And again, we're looking at no contractual adjustment. We've got either a full insurance payment for that, or the insurance has paid something and the rest of it is sitting in patient liability, which we may or may not collect, but is something going on with our charges. As Mike said earlier, net to gross charges can be a false metric. Contractuals are not, in my opinion, your enemy. We want to make sure that we have our charges high enough that we collect every portion, every penny of what is due to us. in the very best way that we can. These items typically look at, is there something going on with the fee schedule? Maybe the fee schedule has changed. We had back in, not ASC specific, but again, a physician example, and that was when we had the large change in the Medicare physician fee schedule. I had a practice that was charging 125% of Medicare, and when those E&Ms went up, in some cases 25, close to 30%, they were actually charging less than their allowables. And so they were leaving $25 an encounter on the table. Again, worth reviewing if you're not in a cycle of doing annual charge master reviews and sort of making sure that you're set at a good target or comparing that to your contracts, worth at least taking a peek to see if there's anything that's happening. Okay. And then similarly, these are items where we can look at, again, the physician, the particular payer, and looking where we're actually seeing, we collected every single penny of that. And why did that happen?
Yeah.
Yes, sir.
Next slide. And kind of pivot and even go to the next one. The next few slides, we're sort of thinking less revenue cycle and more kind of growth oriented within the practice. And so, there's multiple ways to look at this. Janie's going to talk in a minute about referral source reporting and kind of getting at our key referral sources and sort of ferreting out, putting some transparency on that. But to back up before that, we tend to spend a lot of time looking at the payer mix, adjustments in payer mix over time. And a lot of times it's just kind of ratifying that things are basically the same. But because there are such large swings between the various categories, like in the way we have it displayed here, all right, let's take it all and let's sort of index it to Medicare. Medicare is at 100%. Medicare Advantage will be at 100 to 105%. Medicaid for an ASC will be 60, 70 of Medicare. And so it tends to be, a third less reimbursed on the ASC side, maybe only 10 to 15 on the MD side, but way less on this side. Commercial can be anywhere from 30 to 100% more. So call it 130 to 200% of Medicare. And so it's wildly different. And then HIX tends to bell curve around 30, 40, 50% better than Medicare. So 130 to 150 Medicare. And so you see in this example, if you end up with a large shift down in traditional Medicare and up in MA and commercial and health exchange, that tends to move up allowables quite a bit. Obviously, we could have shown an example that is the inverse of that, that even if volume is the same, even if revenue cycle is the same, even if everything is the same, there might end up being a lower amount of revenue per payer. Overall, net revenue collections would be lower simply because of the payer mix shift. Next slide. Then underneath that, kind of continuing Janie's theme of, y'all know this as well as we do, that even within the commercial world, there are significant gaps between your, United contract and your Blue Cross contract. And so being able to sort of track that over time and determine those, tends to be very helpful as well as a predictor of, or, an explainer of what's going on with revenue up and down and to get a hold of those trends. And the example that's here, there's a lot more Medicare Advantage and there's a lot less TRICARE. And for those of you that happen to be around the Savannah or the Warner Robins or what have you area, that tends to yo-yo a lot based on the on campus facilities on the military bases and what they can do when they run out of money or what have you. And so that volume tends to yo-yo up and down. And so on one hand, it could be a lot of, incremental revenue to the ASC. On the other hand, it tends to pay a little bit below Medicare. And so it's not a terrific payer from that perspective. But the overall point is that understanding and having transparency around the nuances in the payer mix trend really help explain getting down to kind of understanding what the net revenue that we should expect, which leads to the next slide, which is a repeat of one that Janie did earlier. But now think about it from the perspective of not the trend over time per se, that now we need to understand why Blue Cross is paying less than it was before. But if there were significant hair mix changes back and forth, then it allows you to know if we have a bunch of volume in this example shifting from other commercial payers to Blue Cross that's now paying 243 per episode when the rest of commercials average would probably work out to be 300. That's a huge problem. That's 15, 16, 17% reduction. Or even worse, if it were moving up into, if the payer mix shift was away from anything and toward Medicaid, this is a really good illustration of what I was saying earlier. If Medicaid's at 151 and the overall average is at 230, then, every time that something shifts there, you're getting about a third less reimbursement. It's hard to keep up when those payer mix shifts are running negative to you, even if volume is staying put in total. Next slide, Janie.
And so then who is driving those revenue shifts, and how can you have some handle on what's happening there? This is looking at kind of our new patient referrals coming into the practice. Sometimes we get really good information on this on the ASC side as well. Depends a lot on what data you capture. Some practices do a really fantastic job of it. My personal bend, I'll make a plug for putting in NPIs because those can be crosswalked and you can get back to individual physicians and kind of group practices. Had a practice before put in, referral source is the billboard on 17. Not super helpful in kind of figuring out where your referrals are coming from. But if you want to make sure where your marketing dollars are going, that can be helpful there, I guess. What we're trying to figure out is, are there groups that have been referring to us and our downturns in volume is this a physician relationship? So group one, we've got some great referrals here, and then all of a sudden we're trending further and further down. This is probably an incomplete quarter, so we'll pause on that. But what's happened? Is that something that's worth our practice manager reaching out? Did we have a doctor retire? Is group one now a smaller practice? And where are their patients going if they've dropped them from that? Versus, some others, overall, we've got some downturns, but wanting to keep a finger on the pulse of who's sending us things, because that's ultimately going to be the lifeblood of the ASC. Huh?
Yeah, and just to kind of repeat, this is a hard one to track, to the ASC per se, because all the volume with y'all's ASCs tends to be from the, your LNR, or even if you're CON, you tend to be fed by your practice. And so that part's not particularly helpful. The leading indicator is the referral to the practice, and then some understanding of the portion of those that are ultimately going to be surgical. And so, that's the volume drop on the ASC side is going to be a very lagging indicator from this kind of reporting that would maybe more early indicate that.
For those of you that are a little bit more graphic, sort of trending what's happening by time, sort of looking at referrals. And then did we pick these up? This in particular was a really bad storm last year. And so a lot of ASCs lost several days and then picked up volume in kind of managing that. And again, paying attention to if you've had situations where you have doctors out, are you capturing that? Are you recovering from that? And where are those things going? Another point in referral source is not just, are you getting the bodies referred from? That was a poor way to phrase that. Are you getting the referrals from particular practices, but what kind of patients are they sending you? Tying this back into what Mike had said earlier, if your patients are shifting, you're doing the same number of cases, but you're getting more Medicaid, that's not really helpful to you because you're having to work harder to maintain more services to maintain the same volume of income. And so we have, group 3, really nice commercial volume and some lower volumes here, whereas group 5 and their referral pattern, still decent commercial, but a whole lot more Medicaid is coming my way. And what is that? And why is that just the nature of their practice and their overall mix, or are they sending these other patients elsewhere?
Yeah, and this is sort of a shot at like comparing to the various referral groups that you have. The other way of looking at this is a single group trended over time. And to Janie's point a second ago, to the degree that Group 5, for example, a year ago was 5% Medicaid, and now it's shifted there, and something in either in their practice or their decision to send to you has now skewed either the volume or the payer mix of what they're sending. That's what you're looking for. And we always say that in each one of these reports, there's always 5 people to say thank you, and there's 5 people to say what happened. And so we almost inevitably find that kind of response needed.
All right. That sort of covers those portions of it. We'll move on to profitability.
Yeah, one opening comment to this section is that, again, the reporting we tend to see sort of tracks total case volume over time. Like the way it's generally looked at from an ASC perspective is that not just as, it's the assumption that all the payer mix is going to be the same, but also that the service mix is the same. And y'all well know, especially if you're in an ASC that has a lot of implants to it, that the relative profitability of cases and whether or not they're even profitable can be at risk. And so what Janie's about to go over is just, I think it's really important for you to be able to pair profitability of the case, as in the revenue minus the specifically incremental cost, into some kind of reporting over time to kind of understand that. Sorry, Janie, go ahead.
Yep, all good. So this first version that we're going to look at is kind of a litany of services that we're rendering, what our average cost of implants, and this is all very rolled up, but what is the average incremental contribution to the facility of doing these sort of services? And so if we've been doing this and we're seeking to project out kind of what cases do I already have on the books, what cases do I anticipate, what is that going to do to my profitability overall for the group? Really sort of a neat way of looking at it. Are these perhaps cases we might need to consider shifting to a hospital so that they may have better reimbursement, they may have better implant negotiation, but at the very least, we're not losing money on the service? Or is this very minimal compared to some of our other profit lines, worth keeping our physicians happy? A lot of physicians prefer to work in the ASC because of the convenience, the ability to control kind of their environment and their scheduling. But letting Dr. A know, these aren't really great cases for us to be doing here, and they're costing us money, is worth a discussion, especially as you get into some of those other dialogues about, draws and how they're seeing profitability and how they're seeing things produce revenue for them individually.
Yeah, push this out one step, and I won't take this too far, but you think about it not just by type of case, but by type of case by payer, and you'll end up with even more nuances of winner, loser, winner, loser, winner, loser. Aetna, this case tends to pay very well. It doesn't have a lot of implants, so therefore that's great. But because there's not an implant add-on for that one, then the heavy implant cases tend to be losers for whatever that particular payer is. And so you can envision that you could roll it all the way out to some kind of a selection methodology where if I want to maximize ASC profitability and avoid all cases that are losers, you can kind of take it to that end and kind of understand, so a really nice roadmap of the ones that are going to be winners and losers down the line.
Can also be particularly helpful if you're pushing up on being at total capacity in the ASC and deciding which cases are worth retaining, versus scheduling out or not being able to do them at all. You just certainly want to choose the ones that are going to be more financially profitable to you. This is just a different cut of looking at very much the same information, just indexing various items one against another. For the most part, the colors are consistent. So cash is always orange, costs are always yellow. And we're just looking at how are things trending the more recent months, because these are based again on date of service. We tend to see fewer adjudication, but what is our profit looking like as we go? And are we at least covering our costs, and by how much? And this can show kind of the changes in reimbursement, new services, new surgeons, things that are just helping us monitor, again, the overall health of the practice and the profitability of the services that we're rendering.
All right, so pivot yet again. I get this as drinking from a fire hose. And again, rather than being overwhelmed by us throwing you, 30 different potential reports at you, um, in our mind, we're just trying to prompt the thinking of back to the core of what are decisions that you're guessing at? What do you not have hard data under? And what's the frequency of the data that makes sense for you to be reviewing periodically? But in this section, we're kind of pivoting again to go into managed care. The Go to that next one. So this one is kind of a general payer scorecard that from our perspective, we're also managed care consultants in addition to being financial analytic um, service providers for, you guys. And so this one is kind of just to step back and look kind of bigger picture at, as I look plan to plan to plan to plan, what are the kind of key metrics there? How much volume does it represent to us? What's their claim turn? What are the denial rates, and to be able to kind of mush all into one spot, being able to compare what portion of my ASC, my practice is it versus what's being paid, what's the problem, what's the pain in the butt factor of dealing with these guys, all kind of smushed into one place. Now, somewhere somebody on the phone is going, "Hey, I'm a client of y'all's. I've never seen this report." That's true because we just developed it and it's going to be coming. But um, we think that being able to kind of lay all this out like that is going to be very helpful and kind of quickly go into that one's administratively a pain in the rear. That one needs to be a renegotiation target, and to be able to kind of see it all in one snapshot just to keep it moving. The next one is this is back to I've shown this slide before, that it's back to the comparison. The next 2 or 3 slides are really about payer transparency, which again, it's a relatively new phenomenon. The payers have to publish their rates that they're paying MD, hospital, ASC, code by code, product by product. And it gives us an ability, and that data is evolving. And Janie can kind of speak to, like, that it's the accuracy of it and the apples to applesness of it is still kind of a work in progress as the various tools acclimate the data to be able to cross it payer to payer and really kind of pull in the provider, the hospital data with that and kind of compare all that. But from an ASC's perspective, our tendency is to want to use this data to either paint the picture that there is a market opportunity of how our particular ASC is being paid versus hospital reimbursement, and to paint the picture how much the payer can save by shifting that volume back to us, and comparing to the other ASCs around us. And I get, this call is all about ASCs. And so not to sort of emphasize the competitive nature of it, but the comparison point going that way as well. And so you'd think that you take a relatively outside of Atlanta market and the reimbursement may be very similar ASC to ASC, and it's not. Just like it's not on the MD side, just like it's not between the hospitals, that it's all about what was negotiated, and there are tremendous gaps between good, best, and terrible within each one of those comparison points. Well, this one, and again, I've showed y'all this before, it's to show that as a leverage point in a discussion with a payer, that we took the top, or at least top 20 codes for a particular specialty, and then compared the reimbursement in that ASC across all the ASCs in the state of Georgia for these codes against the hospital reimbursement for all of these same codes. And you see down the line there that the ASC, y'all's percentage of reimbursement as a percentage of the hospital comes out to be in the mid 30s. So say roughly that the hospitals get paid, I think the overall average was about 3.5 times. So the hospitals get paid 350% of ASC reimbursement on the major codes that are done in ASCs. And that's, from our perspective, we represent hospitals as well, but from ASC perspective, that is incredibly egregious and should be a negotiating point, either from the perspective of push more volume to us, and, payer, you should be saving 70%, all the way through to, you adjust our reimbursement a small amount, and we're still nowhere close to the hospital, and you're still saving money. And so, you should, trying to get the payer to engage that discussion. Next slide. So kind of a little bit deeper dive on this. This is a very specific analysis that we did in the course of a negotiation to say very specifically, if that volume had been shifted to the hospital, what the reimbursement would have been. And so, this particular payer, that particular contract versus if we dropped out of network, what would they have to pay? And again, you see in this case, the ASC is being paid about 130% of Medicare, the versus ASC Medicare, the hospital is being paid 400-ish of Medicare. And so, it's again, to make the point, you can either pay us 15% more or whatever we're asking for the renegotiation, or you can pay them 300% more or incur another $900,000. And so, I will say that it's been a bit of a mixed bag to get the payers to kind of glum onto that and then, kind of throw their hands up and say, yeah, you're right, let's give everybody increases. But it has been an effective point to make to them to continue to move the conversations forward. Next slide. This again is just kind of another look, but this is kind of look at ASC versus ASC. And you see my point here is that you would sort of expect, as I said before, that the range of up to down in any given market on any, for any given sort of service in an ASC would be fairly straightforward. And to a certain degree, you see some commonality up and down, but you see in that first category, the 62323, that the lowest is at, 63%, the highest is at 157. It's, high to low, whereas ASC to hospital is 3.5 times, lowest ASC to highest ASC is 2.6 times. And so that's really, it's a massive difference. And when you think about your portfolio of agreements, if your agreements are, 8-10 years old, and there are examples where older agreements are better agreements. So I don't want to discount that. But if they hadn't been touched for a while with no escalators or what have you, you may be on the low end of that. But now there's no guessing. Taking your portfolio and flowing it through the payer transparency data and kind of coming back with what that really represents is now doable. So don't let that be a data point that you don't know. Slide. And Janie, back to you.
Yep, okay. And so we've got just a few more slides, and I'll go through these kind of quickly because we're pushing up on time, and I'd like to leave at least a few minutes for questions. What we're going to do when we shift from payer transparency, so where does this all kind of come together? And when we're trying to model contracts, especially for ASCs, there's so many different methodologies that exist in the market, and an understanding of those different methodologies and how you convert from one to another is really key in moving forward, because a lot of times you'll have payers that will say, yes, we're ready to engage, and they return rates to you under different methodology that really turn out to be pretty much flat, or if you had some escalators previously, or don't even include your escalators. And so the couple of different ones that we're really seeing lately for ASCs are COPS models, so comprehensive outpatient prospective payment systems, grouper models, traditional Medicare. We don't see a lot of direct percent of charge contracts any longer. Are they adding on implants? Yes or no? That depends a great deal on the specialty that you're delivering and whether or not that's going to be important to you. And are there intrinsic embedded bundling issues that you might not get? Do they have different multiple procedure rules? Because, we used to always see the 150, 25, et cetera, for extra procedures. And now we even see ones where you get paid for the first and nothing for others, or maybe 150. But moving from one methodology to another and just understanding those pieces. So this next one is just a quick representation of, how did we move from a current Blue Cross grouper, what we're charging for these services, and how we kind of moved along. It's similar to Medicare APC methodology, which is what's used for hospital reimbursement, and just again comparing those weights and looking at the increase or the lack of increase there. And then this very last one is looking at groupers plus carve-outs. So when we have those carve-outs, how do those bundle together, and what is happening as we go across that? just driving home the idea that you need to understand your volume, you need to understand your current terms, and what the nuances of a newly offered contract. Just because the dollars seem higher, the individual amounts seem higher unless you're doing carve out to carve out. It's not necessarily a good thing. So anything else on those, Mike? Then I think we are at the end, at least for me, with 3 minutes to spare.
That's the fastest wrap up, Janie. Well done. Well done. Yes.
Well, I guess, yeah, one kind of closing comment is that, we try real hard to sort of have education not be like just trying to sell our services. We're trying to put good information out for you guys to react to. And so I hope this didn't leave you with the impression that this is all a bridge too far and that all of these reports are just like I'd never be able to replicate that. Some of them, you know, with some effort, maybe building it the first time, maybe a little bit, but replicating it may not be that tough. Hopefully, we've sort of left you with some ideas of reporting that you can do that might give a little bit more transparency over the revenue cycle or cash flow, volume, et cetera, that you can react to versus just being overwhelmed with the amount of data coming out of your system and not being able to kind of turn it into something that assists decision making.
I would tack on to that while the reports that we've shown you are the ones that we develop internally to coalesce this information, most EMRs have some form of reporting module that should be intrinsic to that. And perhaps it's just a matter of digging around in your system a little bit and seeing what data points you can get out. Because any data and any report monitoring is going to be better than nothing.
Very good.
Right.
Fantastic, guys. And not only that, Janie, but the background you guys bring to how to tell the story behind the data is kind of complementary to just knowing what to pull from your system. So that's, kudos there to explain those reports. All right, we got 1 more minute. I don't see any questions, but as a reminder, we'll send the PowerPoint out to the attendees, and the recording and the PowerPoint will be uploaded to our website probably the next several days or so. And then we may end up doing a podcast recap as well in the coming weeks if you prefer that format. So that way you can go anywhere to hear Janie and Mike geek out over the data that they just went over. But thanks everybody for joining us, and we want to wish you all a great rest of your day. Thanks.
Thank y'all.
Thanks, everyone.
Bye.